7 years at least, on the relationship between cognition, memory, executive function, etc., and self-care. So this work, of course, as you know, is a group of people that we work with. I've worked with geriatricians, Dr. Christopher Patterson, who's a geriatrician at McMaster, who's an expert in memory and dementia. George Heckman at one point also, we worked with him. There's Norm Archer, who's the engineer and physicist from the School of Business, but he's an e-health person at McMaster, so I connected with him around 2010. Kareem Kashasvi is a family doctor who's an e-health person, and then some other individuals, Jacques-Claude Coillier from Université de Sherbrooke, who's a psychologist but in aging. So very THETA Guadou-Chedar. So we have a broad group of people that, like here, we have people with different expertise, and for me, it's really important to work with people with different expertise because I think they all add to the team. Okay, so I'll talk a bit about heart failure, a very brief overview of epidemiology and management, self-care, cognitive function and impairment, the relationship between heart failure and cognitive impairment, and potential self-care and prevention. So I'll start with a case presentation, and this is how we started thinking about this. This is many years ago. So there's a patient I was following in my clinic, and she was 85, and she was a widow. And she had a history of hypertension, mild renal insufficiency. She lived on her own, and she attended activities at the church every day. So she would take the bus and go to her activities. And I would often see her in clinic, and she had signs of congestive heart failure. And she had a long list of medication, like many of these patients, so, because they have different comorbidities. She had 10 medications to take, and she was self-administering the medication. And I would ask her, so how do you handle those medications at home? And she says, oh, I have this system on the windowsill. I said, don't you ever forget or get confused? Or no, I'm fine. And so she had severe triple vessel disease, had refused bypass surgery. She had preserved ejection fraction on echocardiogram. And she was referred to the heart function clinic because I was having a lot of challenges in my own clinic to follow her. So we like many centers, we have a heart function clinic with nurses that are well qualified in heart failure management. But despite being followed and being taught all the right things by our excellent nurses, she kept having recurrent heart failure. So why? And then I found out eventually that in the morning, before going to church, she did not want to take her diuretic, because if she took her diuretic, then she couldn't go on the bus, couldn't get to her activity. When she would come back, it was too late to take her diuretic. So I kept doubling her dose, but she wasn't really taking it. So, and then there was also a bit of, it seemed to be like, I was like, it's not dementia, but she didn't seem to be quite with it. She seemed to be a bit foggy. And we did a mini mental, an MMSC, and the MMSC was 28. And I'm like, okay, no. So and that's when I started thinking about executive function and wondering about executive function. And what is executive function? It's basically your ability to make decisions about changes you see in your body. For example, in heart failure, that you see that your legs are getting more swollen, you're more short of breath, you're having to wear sweatpants instead of your regular pants, or you're wearing slippers instead of your regular shoes. You have to react to that and, contact the doctor or make some changes to your diuretics, etc. So it's your ability to make those kinds of decisions, or it's the activity of what we call the IADLs, or the instrumental activities of daily living. So why did this patient have issues? It might have been, non-compliance. The whole issue of fluid and salt restriction comes back all the time, even though, like from studies, we don't know how much salt patients should take. Some people at McMaster say we should take more than what's recommended. The medications, are they taking them? The drugs, the different drugs that can cause some problems. The presence of an informal caregiver. This is something we've been interested in, and I'll be presenting you some data fresh off the press. And other comorbidities, the issue of functional decline or frailty, that's an interest of Dr. Heckman, and also the impact of cognitive function. So we know that heart failure is the #1 cause of hospitalization in Canada. A lot of money going into management strategies. In the US also, they have this 30-day benchmark for readmissions. So a lot of energy is going into trying to reduce the readmission rate. The hospitalization accounts for probably 70% of the cost of the management, and we're trying now to shift the cost to the community and try to put more money into the community to prevent readmission, but we don't quite know what's the best way to prevent those readmissions. It affects a lot of older people. As you get older, you get more heart failure, and an important part of heart failure is self-care. So we mentioned that a bit earlier, is your ability to self-care. So what is self-care? There's an individual in the U.S., her name is Barbara Rigel. She's a leader in self-care. She's published a number of papers as well as a tool that I'll be describing a bit later. And it's basically a naturalistic decision-making process that patients use in the choice of behaviors that maintain physiological stability. So basically symptom monitoring and treatment adherence, and the response to symptoms when they occur. So basically how people make decisions in the real world. And there is some data showing that if patients are engaged in self-care, that it potentially can prevent heart failure hospitalization. The data, though, varies. So there's some studies that show that it seems to help. Some other studies seem to say, well, it's not the only thing that may help prevent rehospitalization. So it's self-care is a combination of self-maintenance or being able to adhere to prescribed therapies, and self-management and recognizing early symptoms of heart failure. So in the heart function clinic, it's not unusual that we see people come in, with bigger pants, no belt, no shoes. They have slippers instead. They've had to do all kinds of readjustment to their clothes because nothing fits, because they're so edematous. But they've waited until they've gained 20 pounds before they come to the emergency room. So we know that heart failure patients, they don't consistently engage in self-care. And what are the behaviors? Well, first of all, we talked about medication taking, monitoring symptoms, being adherent to dietary, making sure you're careful about salt, alcohol restriction, weight loss, exercise and smoking cessation, preventive behaviors, and non-prescription medications that you could be taking that may make your heart failure worse. And what are the potential covariates? Well, there are many. So, for example, if you have to manage also diabetes and COPD, it might be challenging to manage your heart failure. Issues related to depression and anxiety. So we know that depression is potentially can manage cognitive impairment, can lead to issues with self-care. The issue about impaired cognition. So does that have an impact on self-care? And I'll talk a bit about that later. Sleep disturbances. So it's not the only issue about do they have obstructive sleep apnea or central apnea. There's a group here in Toronto, Doug Bradley and John Forrest. They're very interested in looking at the changes in sleep patterns that you see in patients with heart failure. But it's not only that. So if you're taking diuretics, they're often up at night to go to the toilet. So then they might say, I won't take my diuretic because I'm going to be up all day. So the sleep disturbances are significant. And if you remember studying late at night and not sleeping very much, the ability to concentrate goes down, your memory is affected, and that's going to affect your ability to react to what's going on in your daily life. The other thing that comes up is poor health literacy. That's basically the ability to read and understand prescription medication, instructions, appointment cards, health materials in order to function successfully in the patient role. There's not only literacy that's important, there's also numeracy. So there's actually a really good paper, I didn't have enough space in my slides to put it in, where it shows that low numeracy is potentially associated with worse outcomes than actually low literacy. And we often don't take into account numeracy or literacy and patient material. And this is very important. And there's been a lot of work done by Darren DeWalt, who's an internist who was at Chapel Hill until last year, and Michael Pignone. So there's a group there very interested in the concept of low literacy and the impact on self-care skills. The other interesting component is the caregiver involvement. So the informal caregiver, so the wife, the husband, the children, what's their impact on self-care, and premorbid intelligence. Does that have an impact? And the other thing I'd like to add, and there's not a lot of data on that, is the socioeconomic status. So, which potentially, although there aren't many papers, likely has an impact on readmissions. So self-care, Dr. Barbara Reigel, she's a PhD nurse, developed this tool called the Self-Care Heart Failure Index. There's also a European Heart Failure Index. They all have their goods and their bads. This is a self-reported validated questionnaire. It looks at self-maintenance, self-management, and confidence. And usually it's scored as poor, good, or excellent self-care, or it's considered as adequate. So if it's more, your score is more than 70, you're considered to be adequate at self-care. Now let's just briefly talk about cognition. So cognition involves understanding and managing independently, and it has different domains. There's memory, there's language, attention, visual spatial ability, and executive functions. Executive functions, we think, are probably one of the aspects of the cognitive domains that is affected in heart failure, and then having an impact then potentially on self-care. Now, what are the different deficits we can see? We have dementia, as we all know, which affects the ability to perform activities of daily living. We have mild cognitive impairment, which is basically a cognitive deficit that will have an impact on your ability to conduct instrumental activities of daily living. It's basically, making phone calls, your banking, those things. So you'll see that the patient can do most of their stuff, but then when it comes to making decisions about banking, they're having a bit of challenges. If you're asking them, for example, to use technology, to use a computer, an iPad, etc., they're challenged with that because that actually they need to use more executive function to be able to use the technology. And delirium is basically usually acute, but it can actually continue and be what we call subsyndromal delirium. So you may miss it, and that actually may continue for weeks and even months. So I remember being on the ward and introducing a nurse to our recruitment strategies, and I was just going through a chart, and I just basically looked at the chart, saw the patient, and said, the patient is delirium. And so I went and called the internist, and I said, well, are you sending this patient home? And she said, yeah, it's fine. She can go home. I'm like, I don't think so. She's got delirium. Well, that's fine. You can deal with it in the community. And I said, well, the risk of readmission is high, and there's also a mortality risk. And so it's missed or, disregarded as a potential serious illness. And this is basically kind of the spectrum of aging. So you have supranormal aging where there's basically no deterioration. There's a bit of loss of memory that's associated with age, and then you've got mild cognitive impairment and then dementia. Okay, so one of the ways to screen for mild cognitive impairment is to use a tool called the MoCA. So it's the Montreal Cognitive Assessment Tool. It's validated in many languages. It now has 3 tests. So if you want to repeat the test to prevent the learning effect, you can actually use different tests. There's all kinds of different parts to it. There's a trail making part, there's drawing a cube, there's a clock drawing, there's some animals, and you're supposed to name the animals. One's a rhino, one's a lion, and another one's a camel. But the problem is that that's cultural. So if you've never been, for example, to the zoo, never been exposed to that, you may have some problems telling that it's a camel or it's a rhino. We'd expect that people know that, but not necessarily. So there's some that are maybe more adapted, so like with the bear and a wolf, or the animals that we tend to see around here. It tests multiple cognitive domains. It's a brief screening instrument. It has to be done by someone who's trained in it. So one of the problems that we've been seeing is that people pick up the MoCA and they decide, oh, I'm just going to do the MoCA. And they don't know how to administer it. It's a psychometric test, so there is a way to administer it, like any other psychometric test, because you need to have appropriate results and you know what to do with the results. It's a bit like the mini mental stage exam, so that's kind of used, sometimes it has a major impact if you have an abnormal MMSE. It potentially can lead to withdrawal of a driver's license. And that has a major impact on an older person when it comes to being able to function on a daily, for their daily activities. So the MoCA is well validated, and we've used it a few times in the clinical setting. Very sensitive, but it's less specific, versus the MMSE, it's more specific, but more sensitive. Okay, so the mild cognitive impairment, usually the score is around 22, but a score of less than 26 means that you have mild cognitive impairment. In Alzheimer's disease, you have less than 26. Their score is usually going to be around 16, 17, that we suspect Alzheimer's. But if you have delirium or subsyndromal delirium, you can have an abnormal MoCA. Could be also issues with language. So if it's not in your language, you'll fail. You know, you potentially could fail because there are some issues that you need to be fluent in English to be able to answer it. So this is an example. So the trail making is basically, for those who don't know, so you go from 1 to A, 2 to B, 3, and then you keep on going. So this is a test of executive function. You're supposed to copy the cube. It looks simple, but we have people that just cannot do it. They'll just do a square or do nothing. And then the clock also is you basically draw a clock with its numbers. It's usually 10 past 11. So you'll see all kinds of clocks. And there's also a clock test that's separate from this test that can be done. And those are like the sum of the animals. And this is one of the tests. This is their original test. And then there's a series of other tests at the bottom of it. So what's the impact of cognitive impairment potentially in patients with heart failure? So there's a potential impact on non-adherence, on failure to recognize symptoms and take action, and potentially an impact on rehospitalization, functional decline, and mortality. So around 2007, 2008, we decided to do a small study in the clinic, and we were interested in looking at just for screening for cognitive deficits. Prior to that time, we didn't really have a tool that we could use like the MoCA. There was a very complex executive function test that had about 20 pages. It was a very long battery, too long to really administer to older individuals. So we looked at the use of the MoCA in the outpatient setting. We looked at patients who were 65 years and over and who were attending the heart function clinic. They had to have no documented dementia, and they could not reside in a long-term care facility, no treatment for depression, and if they were unable to see or hear properly, they would be excluded. So it was a cross-sectional study. It was small, only 44 patients. The MoCA was administered by a trained occupational therapy. And so basically we screened 99 patients, and there were all kinds of reasons for exclusion. And there were 13 who declined. So one of the things we see in these kinds of studies, the people who decline usually have cognitive impairment. They know that they potentially will fail. So they tend to say, I don't want to be tested. So that's sometimes a little hint, okay, and then you have to respect that. But also if you have a poor score, what do you do with it? You have to address it, talk to the family doctor. The MoCA is not a diagnostic tool. So the next step is to refer to a geriatrician or to the family physician. The mean age was 76. 55% were male. 68% were living with a caregiver. They were fairly educated. 68% had a grade 12 or more, and that's when the heart function clinic was at the McMaster site, which is closer to the more educated part of the city. Most of the patients had ischemic etiology. The duration of heart failure was 2.8 years, and 61% had been hospitalized in the last year. So we looked at the day that they had the MoCA administration. Half basically had NYHA functional class 1 to 2, so that's basically the functional capacity. So functional class 1, 2 is no symptoms to mild symptoms. Class 3, 4 is moderate to severe symptoms of shortness of breath, fatigue. Blood pressure was in a normal range, and 33% of patients had atrial fibrillation. So we looked at a group of patients. So we had a large number of people who had an abnormal MoCA. We had about 60% of the population. I don't have the N here, but we had approximately 60% of patients had an abnormal MoCA. So we were kind of surprised. We said, oh, wow, this is pretty interesting. And we also felt we did some statistical analysis, although the numbers were low, and seemed to show that if you had worse functional capacity, you had a worse MoCA. There's also some people suggested that if you have worse LV ejection fraction, you might also have a worse MoCA, but it varies from one study to the other. The studies are often, the numbers are small. Now, the other thing we looked at is the different domains of the MoCA. So if we looked at visuospatial or executive function, it was the ones who had an abnormal MoCA had a significant difference in that domain. The language domain and abstraction domain, as well as delayed recall, which is delayed recall, that's memory. So really what we saw was executive function and memory were affected, as well as abstraction. So those are all different domains that impact patients' ability to self-care. Of course, it's a small sample, and we have a limited number of variables. We did not look for depression. Depression is a covariate to the cognitive impairment, and there was no control group. That's a bit of a challenge, also figuring out, getting a proper control group that has no disease. So basically, we felt that this was a simple tool, easy to use, and that we could, this could potentially be used more in the setting of the heart function clinic, but we realized, we don't have the time to do this. Then we went on to look at cognitive impairment actually following hospital discharge. We applied the heart and stroke because it's grant, and we were expecting that, same kind of proportion, 60% had cognitive impairment. So then we were interested in looking at cognition and self-care. So we measured the MoCA at hospital discharge, and then we looked at self-care when they were discharged at 1 month and 3 months, and we also looked at the MoCA at those separate times. And we called it mild cognitive deficit, because the mild cognitive deficit basically includes the mild cognitive impairment plus the subsyndrome delirium. We did screen for delirium. We were looking at older people that were aged 60 years and over, and we excluded people who had no caregiver, prior clinical diagnosis of dementia, if they had delirium. So we used a tool called the CAM that's been validated by Shannon Inouye in the US, who's a geriatrician. It's a very easy tool. It's basically 4 points, and you can figure out if the patient has delirium or not, and if they were in a residence or were planning to go to a long-term care facility. Why we excluded those patients was they did not have the self-care, so then we excluded them. They were recruited very close to discharge, or like the day of or the next day we would do a home visit. We really tried to get them as stable as possible. The outcomes were measured at baseline 1 month and 3 months, and we used the MoCA. We used the self-care heart failure index, and we also used the geriatric depression scale. So this was an older group of people. They were 78, but this kind of reflects the people we see in the hospital, mostly female. Left ventricular ejection fraction was 47%. We were looking at basically people of all comers with heart failure, not people with impaired or not impaired. They were just impaired and preserved. So both groups. Ischemic heart disease, 43% had diabetes, 85% had hypertension, 74% were treated with ACE inhibitors or ARBs, and 69% were treated with beta blockers. And what we saw was that the MoCA was actually quite low, with 22, and that affected up to 85% of patients. That's pretty scary, because we didn't expect that at all. We were like, oh, our original plan of analysis was that we were going to have, compare the groups, and because we felt, if the proportion was 60 to 40, we could do that. And then we were like, oh, we can't do anything. So we were going to reapply for funding, and we're like, we're not going to reapply for funding. They're going to say you have your answer. And it was pretty obvious, even if we had more patients, maybe the point estimate would be better, but not the actual, the range might be 82%, it might be 87%, but it was significant. What we also saw was that maintenance and self-confidence weren't bad. So maintenance actually got better, but self-management, which is the adjustment of diuretics, reacting to, changing your medication, was poor. This remained poor. And the MoCA improved slightly, went from 22 to 23. There was a slight improvement, but it wasn't an improvement to the point that cognition actually normalized. We looked also at depression. So the depression scale showed that patients were actually not depressed. So that was interesting. We looked at frailty and the Barthel Index, which are other measures. This is just another presentation of the self-care index. And what we looked at was that it seemed like if you looked at change, so there was a significant change in maintenance, no change in management or confidence, and also a significant change in MoCA. Even though the number is small, there was actually a change. There was a small sample size, and there was, again, no age-gender matched group. And as you know, with the Heart and Stroke Foundation, you have limited funding. So even though you'd like to do an age-matched control group, there's no time or no money. We were looking at a selected sample of people, and at that time, the MoCA, they didn't have the other versions of the questionnaire, so we were using the same version, so there could have been a bit of learning effect, but even despite the learning effects, they didn't do much better. The psychologist who was on our group felt that the change we saw was likely not related to the learning effect. But ideally it would have been better to use a different test. So there's a very high prevalence of mild cognitive deficits in older heart failure patients using the MoCA prior to hospital discharge. The ability to self-care is inadequate. And there is some change in maintenance, but not in the management portion. So following that, we sat down and we said, okay, we have to design some kind of strategy. And definitely whatever we're doing in the community, so, having the heart failure clinics and whatever else is going on doesn't seem to work. So we then looked at other studies. So there was a study that was done by Cameron et al. With Simon Stewart. Simon Stewart is a PhD nurse from Australia, and I worked with him when I was in Glasgow. He's a brilliant person, very active in research, and we basically were doing the same things at the same time with John McMurray. So they did a study. They looked at very similar outcomes as we did. They looked at changes in executive function, memory, and attention, how that may impact learning abilities and leading to non-adherence, and how executive function may lead to challenges in making decisions. So they had this study where they looked at patients who were referred to the heart failure program. So these people were discharged. They were looking at younger people, so the age 45 years and older. They had 93 people completed the testing, and they did the SCFE, the mini-mental, the MoCA, and they looked at a cardiac depression scale and comorbidities in the NYHA as well as education. Most of their patients were male, and 42% were living alone. 77% did not complete 12 years of education. So this is very similar to the data that you'll see from Darren DeWalt from the US. The diagnosis, so most of the patients at discharge had NYHA functional class 3 symptoms, and many of them had some degree of renal impairment. So these results were kind of similar to what we had. They had, again, if you can see the proportion, it was really the management. Like, it seems like the management was really the place where people were poor. And there was another study suggesting that we should probably do something about management. So these are potential predictors. So they felt that experience with heart failure, so how many weeks or months you'd been in the heart function clinic and how many years you'd had your diagnosis potentially would impact your ability to be better at self-care maintenance. Self-care management, it seems like the predictor variables were NYHA functional class, the comorbidity index, the presence of MCI, which actually makes sense. And for confidence, there was age and depression also that came up as potential predictor variables. So they had, in their study, 73% of their patients without a previous diagnosis of neurocognitive problems had a diagnosis of cognitive impairment. There's also another study that Fred Spencer, when he was in the US in Boston, that shows around 80%. So it is very prevalent. It's undiagnosed. Patients are more likely to be inadequate at self-care. So there's definitely, we need to tailor whatever education or self-care strategies to this finding. So there was a big study that was, there have been a few studies on self-care, but there was a large one that was called the COACH study, and that was led in the Netherlands by Tina Jarsma, who was really a leader in heart failure multidisciplinary care. And it was basically they randomized 1,000 patients. So this is as big as another study called the DIAL study that was done around 2004, 2005 in Southern America. And they had three strategies, and maybe that's what created an issue where they saw no difference. So the control group was seen by a cardiologist every 6 months. So that's standard of care in the Netherlands. It's not here necessarily. The basic intervention was basically additional visits with the heart failure nurse in the clinic, education and strategies to improve adherence. And then there was an intensive support, so they had that basic one, but they had monthly nurse with phone contacts and home visits and OT and PT and dietitian and social work, and patient diary and heart failure brochures. So it's like everything basically, went to them. So the age group was similar to our age group. So in the 70s, mostly male, EF of 34%, mostly NYC functional class 2 and 3. 42% of the patients lived along the control group and 41% in basic, intensive, maybe a bit less, and they had an elevated NT-proBNP, basically confirming the diagnosis of congestive heart failure with the biomarker. What we saw was that there was no benefit. So you can see that the curve at the top, you don't have a pointer. Okay, just a second. The curve at the top here is the one with, oops, I just pressed on it, is the control group. And then this is the basic support group and then the intensive support groups. There's really no difference between the curves, and the p-value was not significant. There was no significant impact on the combined outcome of death and heart failure hospitalization for patients managed with the moderate or intensive disease management strategy. Now, one of the issues that came up was that, well, the usual care wasn't really usual care, but it was usual care for the Netherlands. And I mean, that's kind of care that should be appropriate for a patient with heart failure, but as you know, many patients aren't referred to cardiologists, even within a hospital. It's not unusual that patients are going to be under the care of internists, not under the care of cardiologists. We sometimes get consulted, and there's some papers from Barry Massey, actually, that shows that you have a better outcome if you're managed by a cardiologist than if you're managed by an internist. There's papers also, I think, by Doug Lee, but there's definitely a gradient in your outcomes if you're managed by a specialist versus not. So there was a non-significant reduction in mortality, not in morality, but in mortality, but increase in short hospitalization for patients in both interventions. So that's not unusual. So if you're watching the patients more, you're going to be admitting them more, maybe preventing longer hospital admissions, or you're watching them more. So we know that about heart function clinic, that's one of the issues. It potentially can lead to more hospitalization, but it potentially prevents unexpected hospitalization. So the next thing we started looking at, well, what about, has anyone else done some work in this self-care? And then I was in Sherbrooke working with Régent Hébert, who's the past Minister of Health in Quebec. He's a family physician, and he's actually an outstanding researcher. Before going into politics, he created a tool called the SMAP, which is a lot like the RIE. And the SMAP is used in Quebec, and he's also looked a lot at dementia and group interventions to prevent hospital readmission or to prevent caregiver burden. So I worked with him when I was there for a short sabbatical to help develop this intervention. And while I was there, I ended up on a lot of the literature that was been written by Darren DeWalt, and he's actually a colleague that we've been working with, and has been at Chapel Hill until about a few months ago. Unfortunately, he left for industry. And Darren has done years of work looking at literacy and looking at adapting interventions to low literacy levels. So most the interventions and patient management material, as you know, are not designed to meet learning needs for low literacy skills. And they've developed, it's been very systematic, very well done. They've developed low literacy interventions to promote heart failure self-care. The material is focused on very key self-care skills instead of knowledge, because a lot of what nurses try to teach patients is knowledge. Oh, do you know what heart failure is about? And it's because your pump doesn't pump well, and the patients, like, they look okay. But what really is important is just to tell them key messages of, oh, what do you do to manage it? And it's like, well, I don't really care what's happening and why it's not happening, and the vessels aren't pumping or the heart's not pumping. So it's really, they focused on symptom and weight assessment and diuretic dose assessment. So they developed this tool. This was their first tool they developed. So it was published in 2006, and it was basically, they had to be in the green zone, and they had a target weight that was determined in clinic. And then they had, if they were in the yellow zone, then they had to watch, and they had specific guidelines. And then if they were in the red zone, they had to call UNC, University of North Carolina, and they called the clinic. So, and then, so this is their first draft. And then you see something interesting here. Do you see this flag here? That's the edema. And we thought that was really great, that, you know, why, and I asked Aaron, I said, so why don't, and then his final one, I don't have a picture of his final one, but in the final one, they took that out, because the patients were confused. They didn't really know what to do with the drawing, and they didn't know how it related to their weight and how it related to the changes in medications they had to do. So they really simplified it, and they just put the weight and the color and how they had to manage their diuretics according to the color. So they took out that pictogram. They said that doesn't work. So they did, following the preliminary studies they did, they went on and they did a large study at different sites. They had about 300 patients in each group. One was a single session, a 40-minute education session that was really geared at specific elements, and I'll talk to you about it. And they had multi-session, which was a patient educator. So it wasn't a nurse, it was a patient educator over the phone who would basically review these key features, and they used something called Teach to Goal. So it's a bit different than Teach Back. Teach to Goal is to make sure that the patient is able to achieve their learning objectives, and then you go back and you know, do you understand? So it's a bit different than Teach Back. So they have a whole document on Teach to Goal. They had a younger age group, so in their 60s, male, female. What you can see is that a lot of the patients had a low income level. So it was really a group of, and these were all people who, so the low income level is usually often associated to low literacy, also in low health numeracy. And there was like 20% of patients who had had more than $40,000, but less than $15,000 US. That's not a lot of money. Education level was approximately a quarter of the patients in the study had an education level of less than grade 12. So the intervention was a 40-minute intervention, and they used this Teach to Goal, and they reviewed how to do your daily assessment, basically use the scale. They were given a digital scale, action planning in case of worsening symptoms, salt avoidance, exercise, and medication adherence. And the outcomes are as follows. It's a bit blurry, but basically for patients, the main outcome was all-cause hospitalization or death, and there was no, if you looked at all the patients, there was no benefit, and you could even argue it was bang on one. Okay, so with a confidence interval from 0.83 to 1.22. If you look at people who had inadequate literacy, again, there was no benefit. If you look at adequate literacy, the point estimate is 1.22, which is pretty interesting. Is it because they're more aware, they have better self-management, that they're going to present to the emergency room, they're going to call more, and then potentially trigger more hospitalization. So that was interesting, despite the fact that, it's a point estimate, the confidence intervals, it's not statistically significant. The only place where it's interesting to see is the inadequate literacy for heart failure-related hospitalization. So the point estimate was 0.53, and if it was adjusted, the adjusted analysis, which included, it was adjusted for site, heart failure quality of life, use of ACE inhibitors, and subjective socioeconomic status, and that was a pre-specified analysis. It was statistically significant. But again, if you know, like me, if you get to that point, you can say, well, maybe it's not that statistically significant, but this was interesting, but it was a large, so they really expected that this would work, and all his preliminary work led to this trial, which was NIH funded, and showed no significant benefit. So overall, it was an intensive multi-session literacy-sensitive intervention which did not change clinical outcomes. And it seems like patients with low literacy may appear to benefit from the multi-session from a hospitalization perspective. Now, what we looked at, we said, okay, well, let's assume that everyone who's discharged from the hospital, they're all cognitively impaired, which is what we've actually demonstrated. And then we said, well, why don't we look at studies that have looked at the role of the informal caregiver? And that's actually a cheap intervention, not costly. And there have been actually studies with stroke and dementia. But briefly, because we're running out of time, those studies have all had a significant impact on caregiver burden, delay, and institutionalization, I can't say it in English, institutionalization, and hospitalization. So these have all been actually beneficial. So we were like, and then Régent Hébert was like, well, why don't you have these group meetings? And I'm like, well, it's not like dementia. You know, the caregivers, the patient's still able to care for themselves. So, and then it's also they're older. They don't have that the financial means is an issue. So we didn't feel that a group intervention would work. And there's actually a group, another study that's been done looking at that, and it was done by Maastricht, and there's no benefit of an actual group intervention for heart failure patients. We looked at all the kinds of ways you can address it. So we said, oh, this seems pretty appealing. And so I felt like the conclusion of the study showed that it was published in BMJ, showed that training caregivers in basic nursing, moving, handling, and facilitation of activities of daily is feasible. It would significantly reduce their burden, anxiety, and depression, and improve quality of life. Patients whose caregivers received training reported better quality of life. Mortality, institutionalization, and disability were not influenced by caregiver training. It was a small number of patients, though. Okay. So we designed a study. It's called the C study. I can't remember. I can never remember the acronym. We all come up with these sexy acronyms, and I'm like, okay, what does this one mean again? So it's basically looking at a complex intervention, which includes a digital scale, but our scale is basically a talking scale, because when we did the work on cognitive function at discharge, we found out that a lot of people had actually problems with visual acuity, and they couldn't see their scale. So we said, okay, that's part of the intervention. So the patients would get a digital scale. For the patients who were actually very obese, we had a specific obese digital scale that would talk to them. We designed a diuretic decisions tool, but based on Darren DeWalt's tool, but which was less aggressive than theirs, because in the top end of their diuretic tool, they were using thiazides, they were at very high doses of diuretics, they were also cutting back on diuretics, and we felt for older people who have dosettes or prepackaged medicine, that would not work, that they would not be able to do that. But adding a diuretic with the PRN bottle was doable. And we wondered, I was like, oh, how do I do that? And Régent Hébert said, well, what do you do in the heart function clinic? Well, I said, I give them a bottle of PRN Lasix. Well, you're going to do the same thing in your study. I'm like, oh, okay. So that's what we did. And we had a tool to contact the family, basically a heart failure specific discharge tool for the family doc. It was a one-page, what were the potential triggers to readmission. It was sent to the family doc. And then we had also a nurse who went to the patient's home and had 6 sessions with the patients and was using the Teach to Goal that Darren DeWalt developed, and their little book, which is a very low literacy booklet for heart failure, very, very simple, easy pictures to understand. And then she went on 6 occasions. So it was 5 visits, 1 baseline visit for everyone, and those visits at 1 week, 2 weeks. And then the key thing that Darren DeWalt comes back to is the repetition. Is going back and repeating and repeating and repeating. Especially if you have cognitive impairment, you'll need a lot of that, and you'll need someone else who's listening. So we looked at males and females. We excluded people who were who were going to go to long-term care facilities because they don't have to self-manage. Patients who were on hemodialysis because they don't need to manage their volume. And they were recruited within 24 hours to 48 hours post-discharge because of the weekend. This was funded by HASO, which is the AFP, the Alternate Funding Plan funding. This was our tool, so it's a similar tool, and it was a booklet. And we also tried to use technology for this one, and we were like, oh yeah, this will work, you know, iPad. And we had two or three smart, older people who had the knowledge of technology and knowledge, you know, who were well educated, high literacy. They both failed completely. Like, they couldn't enter staff. No, so we were like, Norm Archer from the e-health program was like, wow, this was an eye-opener. So we were like, okay, let's drop that and just do it with paper. And people love the paper because they bring their paper to their doctor, and it's a bit like the work that Anne Holbrook did when she was doing the work on her diabetes management, etc. So her risk factor management. And this is what it looks like. So they had the diuretics at the back. The nurse would tell them exactly what they have to do, and they had clear instructions of what to do. We use the Self-Care Heart Failure Index, the caregiver burden, and this is preliminary data we've just finished. And this data was presented in Vancouver at the CCC to an older group of patients. So this was a feasibility study. So we really wanted it was a proof of concept and see if we could actually do it, and then move on to getting more funding to do a larger study. There was a bit of imbalance between groups, like from a male-female perspective. Ischemic etiology was kind of about the same on each group. They all had heart failure confirmed by the Boston Heart Failure Score. Overall, the left ventricular ejection fraction was almost preserved. Use of ACE inhibitors was actually low, which is pretty interesting. And the use of beta blockers was in the range we'd expect. And most people were all supposed to use a diuretic at discharge. There was like one patient who was sent home without a diuretic and then was on a diuretic within a week after because it was the physician who discharged him forgot to prescribe the diuretic. And then we looked at the BIFID score, which is a comorbidity index that's been developed also by Sharon Inouye. So it's much easier than the Charleston Comorbidity Index, and it's specific for older people. And that's a moderate degree of comorbidity. So we looked at patients, it was a stratified randomization. So patients were randomized into the intervention or not, but then it was stratified if you had a caregiver or not. The non-caregiver group was done at a later date. So after we met with Darren DeWalt, I said, well, we've got about 20% of people like we're excluding from the intervention because they don't have a caregiver. He says, well, why don't you stratify the randomization? I said, oh yeah, that's a good idea. So we started later to recruit them. And what we saw with these patients was that there seemed to be, for maintenance, there was no significant improvement. It seems to both groups seemed to improve. For management, they were all low. And there seems to be some improvement here, but we don't know if it wasn't statistically significant. It could also be a fact that it was a small sample size. And then we looked at confidence, and again, you know, there seems to be some improvement for the intervention group, but again, it's not statistically significant. Now, if you look at the N here, is a mistake, a typo in the N, a bit lower than that. If you look at the Self-Care Heart Failure Index for the patients who had an informal caregiver, we see an improvement in maintenance, which was quite statistically significant. This is a surprise. And when you do a trial, you're like, okay, we'll see what happens. And then the management improved, but wasn't quite statistically significant. Confidence was also significantly improved. Then we looked at the caregiver burden, and there was actually no significant change from a caregiver burden perspective. We've also looked at knowledge, health belief questionnaire, and we have a whole set of other questionnaires. We looked at literacy, socioeconomic status, so we have everything else that's kind of to look at. But these are the preliminary results. And concluding the talk, so the first RCT that evaluates the impact of informal caregiver, the role of the informal caregiver on self-care. We've proved feasibility with good adherence to the use of the diuretic decision support tool. It was always filled. We looked at if it was the patient or the caregiver who filled it. We were just interested really as long as it's filled. We're happy with that. It's a home-based intervention with repetition of key self-care aspects, and we plan to evaluate it in a larger setting, including a look at cost effectiveness, because this is a quote-unquote cheap intervention using someone who's already with the patient. Thank you very much.
what do you think the mechanism is to improve the patient self-care?
I think it's because the caregiver is actually potentially doing a lot of the work. But it's interesting because the patient self-care, and I think it's a confidence issue. Yeah. So we did self-care, and we also did the self-care heart failure index in the caregiver to see if that changes, and it doesn't really change. It seems to be really the impact is on the patient. I don't know if it's an impact on confidence. They're working as a team. So we've done interviews, a bit of qualitative research after to find out, what did you feel helped? They felt that the nurse visits were really good because they could ask her questions, and it wasn't geared at, the nurse wasn't there to manage their diuretics. So there's CC&E, we have and it's probably like in Hamilton, we have, I don't know how many programs going on, and they're almost stepping on each other's toes to get to the patient. So they had the CCEC going in, and despite that, it was really the nurse would just focus on those key aspects of self-care, what to do with your diuretic tool, how to react, and how to contact, and then the patient really feels empowered. I think this tool actually made a difference because the patients often you tell the patients in the heart function clinic, the nurses say, oh, if you have a gain of 2 pounds or 3 pounds over 3 days, call your doctor, adjust your diuretics. And what we found out from the qualitative interview part is that the patients, if they don't know, they don't have this knowledge of what to do, they're not going to do it. They're just going to leave it to the doctor or to the nurse to fix it. So this was actually really empowering. We don't know which part of the intervention works, and I had a discussion with Lehadan Tabain about that, and he says, well, that's the issue with complex interventions. They're complex problems, so you need to design a complex intervention that's going to kind of address the issue. So we were hoping, the problem with this kind of research is that it's difficult to get funded. So for example, trying the CIHR clinical trials, being at Celine's place, we're competing against, PG Devereaux and poise number 5, or I don't know which poise, but so we're competing against drug studies, device studies, even though people like Jean Rouleau say, yeah, this is what CIHR is looking for, we want these comparative effectiveness clinical trials. I said, well, CIHR, the RCT committee is not interested in funding these kinds of studies. So, plus healthcare is very provincial based, huh? So I have a lot of good buddies in Quebec, but there's the totally different from a community service perspective. They're not developed at all like Ontario. There's a lot of money going into community service in Ontario versus in Quebec. I think they're kind of still waiting. First of all, they're cutting budgets, and they're still kind of waiting to figure out what actually works or not. I think Jean Hébert was trying to get money into the community, but now that the Liberal government's back, there's going to be a lot of cuts to. And then, well, you have to look at different models. Like, could we do the study in BC? Yes, we probably could do it. They have a similar model as we do. Alberta, also probably Nova Scotia. But it's, I'm not sure what is the aspect that's helping, but it's really, I don't know if it's an aspect of building confidence. There's someone else who has the knowledge. What I've seen in clinic, that's anecdotal again, is that they seem to, the people who have the best caregivers seem to do much better because there's this doting wife, for example, who will, measure their weight and document the weight, or this doting husband who's there with his handbook and who's basically in charge of the condition versus patient who comes alone and is a train wreck. But again, that's anecdotal. I see that with Italian patients that, the wife is so dedicated that measures the abdominal girth and has everything documented. And it's funny, but it actually makes a difference to their management because quickly they call the heart function clinic or they say, I've done this or that. They are able to react appropriately and they're replacing, that patient who has this mild cognitive impairment. They're helping over. But we call them, in our study, we call them the care partner. We didn't call them the caregiver. We call them the care partner because they're actually partnering with the patient. It's not like a patient who has dementia or stroke where you're really dependent on your informal caregiver. Mary, you had a question.
So what I took away from this is that these are hard. You would think that relatively diuretics up down, you have trouble. these kinds of interventions seem to have trouble with concentration and effect. So do you have an idea why heart failure clinics seem to be so effective, whereas other behavioral health interventions don't seem to be effective?
So the study with Darren DeWalt, I think he didn't have a high-risk population. So they picked patients that were stable in their heart failure clinic or their outpatient internal medicine clinic. And I think that that's why he sees that, this probably didn't work. I think you really need to pick those high-risk patients, identify those high-risk patients. And then I think the heart function clinic is the intensity of the follow-up and the quality of the physicians and the nurses that are following the patients. I think that's really what makes the difference. Because if you look at
very little of that behavior enhanced adherence to drugs or better self-monitoring.
I personally find that maybe in younger patients, and anyone who's less than 60, maybe, those patients that are really sick, they're almost pre-transplant, and they end up in the heart function clinic, and they're going to be like so dedicated, they're going to follow everything to the letter. But those older patients, they become very dependent. I find that actually instead of improving their self-care, I find that they become dependent on the clinic because some will call all the time. What do I do? How do I change this? Even though they've been shown, okay, this is how you're supposed to react. It's created some dependency. So this is, so we're very interested. So what we'd like to do is pursue this. But we don't know what we're going to do from a funding perspective, plus with everything else that's going on. But if you think of it, it's a cheap intervention and using someone who's already there. And you could argue that you potentially could use formal caregivers that are non-nursing to potentially, help patients with this kind of tool.
In this patient population, among those with informal caregivers, is it feasible to put in something like telelinks in order to manage their condition?
Okay, so we've talked about telehealth. So there's actually 2 large clinical trials that have shown that telehealth shows no benefit in heart failure. And one is from Harlem Krumals, actually, who's the big outcomes research guy, and one was published in New England, and the other one was published in Circulation. So despite the fact that there's a lot of work being done in telehealth in Ontario, there's 2 large clinical trials actually showing no benefit. And then from our work we've done with technology, even using iPads or even this simple tool, which was on the computer on a website, patients were having a lot of challenges. So my concern with the use of technology in older patients, and most of them seem to have some degree of mild cognitive impairment, especially with executive function, it may be the reason why those clinical trials showed no benefit, because there was no impact on mortality. And that's in a selected, when you think about a clinical trial, it's a selected group of patients that, they fit the eligibility criteria. I think it wasn't just the technology part. The big thing about the telemonitoring trials that we think that why they didn't work was that they weren't seeing the patient. So it's a big difference. So let's say you tell me 2 days ago, I got a call. Oh, Catherine, Mr. Smith is he's not better. Do you think we should put him on Melrano? And I'm like, I can't make a decision unless I see the patient. So it makes a big difference for me to see the patient and look at their legs. So when I was in Glasgow, and that's actually what it was really inspiring, I was working with John McMurray, and the nurse asked me, Catherine, do you want to do some home visits with me? And I said, yeah, sure, I'll go. And we were in the very poor, one of the poorest area of the UK in Glasgow. And then that's when I realized it really hit me. And I'm like, okay, this is why patients don't come in, is that they don't have the money to come in. There's a lot of alcoholism in that area of the city. They're poorly fed. We had a patient who had an indwelling Foley, kept tripping on it. Then we had another one who didn't even know how to open the pill box. And it was like, that was an aha moment. It was like, whoa, okay, so even if I had telehealth for these patients, I have to see them. I have to see that, oh, they've got swelling up to the ankles, and because they won't tell you. They come to the clinic and they've gained 20 pounds and they're like, and I said, did you notice that you're swollen? Yeah, I've gained a bit of weight. And I'm like, and then they don't make the relationship with worsening heart failure is related to, you know, goes up with worsening leg edema. And it takes them forever to understand that. So that's one of the reasons we think potentially the telemonitoring clinical trials didn't work. The fact that patients weren't seen. And what actually, when you get the feedback from the patients, they say it was the nurse interaction that they enjoyed the most. Like that they could ask the nurse questions, they could verify if the behavior they had adopted to do the self-care, was it appropriate? There was the feedback. And so if it would be integrated with CCAC, you know, like doing that rapid response, for example, that was the next step for us. It was to work with rapid response and integrate this strategy, you know, randomize patients to regular rapid response versus a more intense rapid response.
So now, no more questions. No more questions. I'm sorry, but we're way over time, and so I just want to conclude the official part of the round, and I'm sure maybe you can ask separately. So thank you very much.
Thank you very much.
Thank you.
Great. Thank you.